Thank you for the applause. I haven't done anything yet, but thank you. So I am sure, without question, when you all signed up for this conference, you were probably thinking to yourself, you know what would really pull this conference together? You know what topic I absolutely want to hear somebody talk about? Economics. Because it doesn't get much more exciting than that, does it? Like, how many of you really enjoyed your economics classes as an undergrad? Okay, you are all lying. Don't sit there and lie. I know you didn't, right? If I could go on and talk about our fractional banking system and the role of the Federal Reserve, I can assure you none of you would even be remotely interested. So knowing that we are done with this wonderful lunch, I will try to be as informative and as entertaining as I possibly can be, which is a tall order given the subject matter. My name is Jason Goldwater. For those of you that can remember, I am not related to the senator from Arizona, except when I'm in Arizona and then he's my cousin. And I get incredible discounts when I'm there, unbelievably so. I am the President and Chief Operating Officer of Laurel Health Advisors. We are a small women-owned business in Laurel, Maryland, so a long way away from here. It is absolutely a delight to be here, to finally get to see Wendy and many others, Sarah Bates, in person finally, after I have only been seeing them in Microsoft Teams windows for the last year. And of course, it is great to be here amongst our wonderful friends and close colleagues at Ingenium Advisors, who really are the ones that introduced us to Wendy and the work that we have been doing with Thriving Together over the last 6 months. So I am here not really to lecture on economics. I mean, I was sort of kidding about that. What I am here to talk about is some of the work that we have done with Thriving Together to talk about what the economic impact of telehealth was on the region, but then to expand that to talk about what the economic impact of telehealth is overall in rural America. Now, I've been working in telehealth since 2002. I started with the Centers for Medicare and Medicaid Services. I actually started when it was HCFA. That is how old I am. I am not going to date myself anymore. And I started with the use of virtual teleconference visits for children as they were doing their early periodic screening, diagnosis, and treatment protocols before they entered school, all of which were in rural areas that were covered by Medicaid. And I saw the future then in 2002, and of course it took 21 years in a global pandemic for everybody else to catch up. But I'm glad we're at this point now, and somewhat of an inflection point, of really beginning to understand what the value and the utility of telehealth is. And I think Christian and Kathy and Trevor have done a phenomenal job of being able to map the telehealth work to workflows to show how efficient it is from an operational perspective and what the benefits could be. And what I am helping them with, and what my wife, who is the CEO, of course she's the CEO, she's not here. She's reminding me every 10 minutes that she's not here and that she really would like to be here, and is continually reminding me that she is the chief executive and that she can fire me whenever she would like to. It's great. We've been married for 24 wonderful years. What we have been helping to do is really understand sort of what that cost impact was be. How much money are patients saving through telehealth? How much are providers saving? How much would payers save? And what that would be compared like to in-person care. Now the caveat here is that this is not which one is better or which one should you prefer. It's if you are looking at somebody going to get care in person or somebody that's looking to get care virtually, what is the cost difference between the two? If there isn't one, then they're both equal. If one saves more money, then it means that telehealth should not be discontinued or shouldn't be reimbursed at the same level of in-person care if you're getting roughly the same benefits. All right, this is the most entertaining slide that I have because it's animated. All right, so what am I going to talk about? So I'll talk a little bit about the economic landscape of rural America. I know most of you already know this, but there are some statistics to keep in mind as we go through this, to talk about the economic impact of telehealth, to talk about what that return on investment analysis would be, to talk about success stories. Now, the work that my wife and I have done, she's been in telehealth since 2000. Her name is Dr. Yael Harris. Some of you may know her from when she was at HRSA a long time ago. Yael has been involved in telehealth for a very long time, particularly in rural health centers and in federally qualified health centers. And she really is the one that understands where success is. And our work over the last 3 years since we were founded has really been looking at the economic cost effectiveness, cost impact of telehealth across the United States. And we have found that there are some success stories, not just with the use of telehealth, but also what money it saves and how effective it is. And then really to talk about what the future outlook might be. Okay, so there is absolutely, and I think I'm preaching to the choir here, and Kathy and Christian articulate this far better than I would, which is the real need for telehealth in rural America. And why do we have to have it? Well, largely, obviously, it expands access, improves the quality of care. It minimizes challenges to care. There are many challenges to individuals being able to get access to care, and I will talk about some of those a little bit later. And the burdens that those patients encounter. When you talk about a patient needing to go see somebody in person, it's not just they have to get into a car and drive, right? That's sort of simplifying that. They may have children. They may have an elderly parent they're taking care of. They've got to find somebody to take care of the children or that elderly parent. They may be working at a job that pays hourly, in which if they take time off, they're not getting compensated. So they lose wages, they lose money every time they have to go out and go see a doctor. And if that doctor is 100 miles away for what they need them to do, you're talking about an entire day lost and a significant burden on patients to be able to get the type of care that they need. And furthermore, with the advances of telehealth, now mind you, when I started, it was just video conferencing, right? And it wasn't on a laptop. We had no Zoom. I'm really dating myself here. It was just a television screen. And you could code a video hookup, and you could talk to a provider on a giant television screen. We have obviously advanced to that point. But with the advances in telehealth, not only are we able to connect with a physician through video, but we are able to monitor, we're able to provide timely care, we're able to communicate more consistently, and we can all do this within the confines of the healthcare system. All right, so this is an important slide to remember because I don't think people really understand and really conceptualize sort of what rural America is like. You know, my son, who is 15 and who acts like he's 25, I'm sure all of you have experience with this, we were in Oregon for our vacation. We were on the coast of Oregon. Beautiful, lovely place. We were in Seattle first. He thought Seattle was okay. Not really his scene, but we got to the coast of Oregon. That was much more his scene. But have any of you been to the coast of Oregon? A lot of you. All right, so a lot of you have been there. So as you're going through these towns, they're not major cities. There's no Home Depot, thank goodness. There's no Starbucks. I know, what a shock. There's no Target. The conveniences that he's used to are not present. And so he says, "Oh, Dad, this is rural America, isn't it?" No, this is not. This is small town America, but this is not rural. If it were rural, none of this would be here. You would only see very limited areas of where you could get things. And he just has a hard time conceptualizing this, but my wife and I, who have worked in rural health for 3 decades, realize that he's one of 100 million people that don't understand what rural America truly is. And I think this slide really shows sort of the gap between rural and non-rural, that the employment rates in non-metro counties in rural have not really recovered since 2007. Since we were in the Great Recession, we still have a significant gap. And that this is why I think telehealth really becomes important, which is this next slide, which shows that the average rate of doctors in rural America, which are the solid lines in this graph, are substantially lower than they would be in metro areas. And it's even worse, not to be overly negative, I'm not a negative person, but overly negative, that they estimate in 2030, the amount of specialists in the United States is going to drop by about 20%. By the time we get to 2040, that attrition rate will have doubled, which means doctors such as cardiovascular surgeons, endocrinologists, neonatologists, those that specialize in the care that people need, nephrologists, are going to be far and few between. What is even more striking is they're saying the rate of psychiatrists is going to drop by 2% every year starting in 2030. And when we think about the gravity of the mental and substance abuse crisis that is within us, that is very, very significant about having those provider shortages really put people at risk. Now, why that's happening is an entirely different keynote address at an entirely different conference, which I'm not going to talk about. But what I am going to talk about is, in order for us to make sure we are getting people the care that they need and to make sure it is being delivered timely, given the fact that we have a shortage that is only increasing, really underscores the critical necessity of telehealth. So when we look at the economic impact, what do we look at? So from a patient's perspective, not a provider yet, not a payer, but from a patient's perspective, how do we figure out what these savings are? So the first is a reduction in travel. Now, in some cases, so when we did a cost-benefit analysis 2 years ago for Congress, we got data from across the country during COVID, like right in the heat of COVID, March through September of 2020. We are right in the middle of it. And we got over 1.5 million encounters of telehealth visits across the United States. And we got them in rural areas and we got them in urban areas. And in urban areas, the travel was minimal. So in New York City, for example, where we analyzed those individuals 65 or over, their biggest health condition at that time during COVID was related to cardiovascular issues. But it's New York City. There's a cardiologist every 25 feet. You throw a quarter, you're going to hit 5 of them. So, and you don't even really have to drive, you can just get out and walk. So what we found in New York City is they could find a cardiologist whenever they wanted to. But in Arizona or New Mexico, that's not the case. So cardiologists or specialty surgeons, or specialty providers rather, were significantly far away, averaging anywhere from 50 to 120 miles one way. So imagine how much that cost them to be able to get into a car and drive there and back again. It is significant, not factoring in the gas and factoring in they may not even have a car to begin with. Then there is lost wages. So a lot of people that are living in these areas that are using telehealth are working hourly jobs if they are working, which means, again, if they take off, they lose money. So if you use telehealth, you may be losing some money from the time that you're interacting with the provider, but you're not losing nearly enough if you're driving 100 miles one way. Then there's reduction in hospitalizations, and we found conclusive evidence of how many hospitalizations this would reduce, anywhere from 10% at the minimum to 70% at the maximum. And the reason hospitalizations were being reduced is because people had care when they needed to access care. They were not waiting until their condition exacerbated to the point that they then had to go to the ER, because you know, if something's wrong with you and you do not have easy access to a provider, what are you going to do? You're just going to sit there. You're not going to go. If you have to get into a car that you don't have, or you can't afford to take the time off, or you can't find care for your adult or for your children, you simply are not going to get it, which makes the situation worse to the point that you end up being hospitalized. And there is no greater driver of healthcare costs than hospitalizations. And then there's lower overhead for providers because you're not renting a facility, right? You're not in a care center providing care all the time. There are plenty of providers that are delivering telehealth from the comfort of their house. I know many of them, way too many of them. What are the indirect costs, indirect savings? There's improved health outcomes which lead to reduced costs. Improved outcomes because of the ability to access care. So cardiovascular disease is a big one. So there are plenty of devices now, ranging from remote EKGs to teleconferencing on a regular basis, to other remote monitoring tools that indicate when a patient is having a condition that indicates medical intervention is necessary. And that intervention can be done by a provider before it exacerbates to the point that something significant has to be done. An emergency service, moving to an emergency room. So if they are able to intervene at that point in time to stabilize the patient, either by providing care to their house, providing medication, ensuring they are taking their medication, it reduces the risk, doesn't eliminate, It reduces the risk of an exacerbation of a condition that would lead to significant cost. And furthermore, as I think all of you have realized, and I know because I have heard Christian and Kathy talk a lot, and they are wonderfully articulate about this, about how preventative care can be exercised through telehealth. You can tell somebody, here's the diet you should follow. Now, that doesn't mean they're going to do it, but you can tell them what it should be. You can tell them what kind of exercise they should do, when they should be checking in. You can provide them with a remote blood pressure monitor and see what those readings are and interpret them. There are a variety of ways that you can exercise preventative care before it becomes critical. So when we did this analysis here, so we took all those factors in, and we looked at 3 different settings. We looked at a federally qualified health center, we looked at a hospital, and we looked at a rural health clinic. And we calculated the per person savings from each of the 4 counties that comprise Thriving Together. And we looked at indirect and direct costs. And you can see that there were rather significant savings per person, ranging from anywhere from $101, just over $101, to $165, anywhere from $56 to $92. It just depends upon the setting. But in every one of them, patients were saving money because they were able to get their care in their house. Now, some people would look at this, and trust me when I tell you that our Congress looked at this and said, well, not this specifically, we had a much bigger chart for them, but they looked at this and said, well, what's the big deal about that? You know, so a patient saves $100, why do we care? Okay, but think about all of the people that may have a particular condition. If they use telehealth instead of not getting care, what would those savings be? And when you look at this, you factor in each of the conditions, and you figure in the population percentage, which we were able to get, of people that have those conditions. And when you factor in the direct and indirect costs, now this becomes significant. The overall patient savings for people that have major depressive disorder in Douglas County is almost $9 million total. Almost over $21 million in grant, and it goes all the way down. There are significant savings. Now, I do want to be careful about this. This is not saying telehealth is awesome and you should only use this instead of in-person care. Let me be clear. I'm not saying that. I would never say something like that. What I would say is when people talk about telehealth might be overutilized, if we give it reimbursement parity based on in-person care, people might overutilize it. We don't know how much money it's going to save the patient. We don't know how much money it's going to save the system. This data, with the most basic of analysis, shows that there are significant savings. So what is the economic impact on a larger rural health scale? So in terms of job creation, it really can factor into that. There is telehealth infrastructure you need, tech support, equipment, maintenance, et cetera. And then you need service providers, remote specialists, consultants, et cetera. What we told Congress, what we've told others, is in addition to the cost savings, there's also a job creation aspect to this, the level and percentage of which varies based upon the need, but there is always a need when you set up a telehealth system about what that job creation could be. There's an impact on local clinics, enhanced service provision without the need for relocation. You can provide the services in your house or in the clinic, remotely or in person, and you can also work with specialists that are connected to your clinic through telehealth to provide services through telehealth partnerships. So when we look at return on investment, so this is the other thing everybody wanted to know, right? So there's 3 things when people talk to me about telehealth, and they want to talk to me about the economics, which is not a lot of people. But when they do talk to me, they want to know what's the cost benefit to patients, what's the return on investment if I decide to engage in this, and how cost effective. And the cost effectiveness is for the real economic nerds like me. But they want to know how effective is it. So when we look at return on investment, it's really the initial investment in the technology and then the training and the development. The recurring costs are maintenance and software updates and licensing. And again, this is really any use of any software in any industry. This isn't just unique to telehealth. There is always the cost of building the system, to training, maintenance, and updates. So when we look at the return on investment, one of the scenarios that we did was virtual urgent care. So the way that we set up virtual urgent care is we looked at a set of claims that were just virtual urgent care. And then we looked at a set of claims that were urgent care, the quote-unquote doc in a box. I never really enjoyed that term, but I don't know what else to call it right now. Primary care and emergency room care. And we found all of the conditions that were what would be considered non-emergency conditions. So somebody want to take a guess about the one condition in 2020 and 2021, taking COVID out of the picture, the number one condition people sought for virtual urgent care? Guess. I have silenced the crowd. Astonishing. Okay, dermatitis was the number one, right?